Hello, everyone, and welcome to today's session, Access to Care, Navigating Breast and Cervical Cancer Screening. My name is Melody Schaefer, the Manager of Community Health at Siteman Cancer Center, and I will be your host. If you haven't participated in the pre-test, please take a moment to do that. We will also have a post-test at the end of today's conversation, and we'll share the results. I'd like to start by introducing today's panelists. Cameron Smith is joining us from the City of St. Louis's Department of Health. He currently serves as the Regional Program Coordinator for the Missouri Department of Health and Senior Services Show Me Healthy Women program. Helen Blair, a breast health nurse navigator at Christian Hospital, works directly with the Show Me Healthy Women program, enrolling patients in breast health services. Dr. Michelle Silver is an assistant professor of surgery in the Division of Public Health Sciences with Washington University School of Medicine. A large portion of her research focuses on screening and prevention of the human papillomavirus and cervical cancer. Dr. Lindsay Kuroki is an assistant professor in the Division of Gynecologic Oncology with Washington University School of Medicine. Her research interests include cervical cancer prevention and cancer disparities among women with unmet social and financial needs. Nicole Cope is the executive director of the Missouri Immunization Coalition. She comes to us today with over 20 years of experience as a health provider and senior leader in the U.S. Army Medical Corps. A recorded version of this webinar will be available on Siteman PECaD's YouTube channel. A link to that YouTube channel should be in the chat feature. We'd love to hear from you today during today's conversation. Please use the chat feature throughout the presentations as you react to what the panelists are saying. We'll be using the Q&A function of Zoom to pose questions for our Q&A portions. You can find that at the bottom of your screen near the chat feature. Please enter your questions directly there. For those of you just joining us, welcome to Access to Care, Navigating Breast and Cervical Cancer Screening. I'd like to invite Cameron to begin our presentation.
Hey, good morning. My name is Cameron Smith. I'm a registered nurse with the City of St. Louis Health Department. I manage the Show Me Healthy Women program in the St. Louis area, and I'm here to tell you what the program is and why it's a great resource. So let's see. So we can go to the first slide. All right, so some quick background. Breast cancer is the most commonly diagnosed cancer among American women. According to the World Health Organization, or WHO, as of 2021, it is also now the most common cancer in the world. For Missouri in 2017, which is the most recent data set for CDC, there were a little over 5,000 new cases of breast cancer, and unfortunately, about 867 women passed away due to breast cancer. Now, cervical cancer was one of the most common causes of cancer death for American women as well. That's changed in the past 40 years, however, as the death rate has dropped significantly with increased use of the Pap test. So now I've got a little background, where does the program fit into the equation? So if you can go to the next slide for me. So you can click kind of ahead a little bit. Yeah, just get it all up there. So Show Me Healthy Woman is Missouri's section of the National Breast and Cervical Cancer Early Detection Program. Really long name, good program though. It was passed by Congress in 1990 to provide cancer screening for underserved women in the US. The program is managed through the CDC and recognizes that early detection relies upon having access to regularly scheduled screening services, such as clinical breast exams, pelvic exams, mammograms, and Pap tests. Show Me Healthy Woman helps eligible women gain access to those breast and cervical cancer screenings in a timely fashion, and it connects them with further diagnostic or treatment services as necessary. Patient navigation and case management services are also included in the program in order to help women overcome some of the barriers to receiving adequate care, such as confusing health systems and lack of transportation to and from appointments. Show Me Healthy Woman actually provides travel vouchers to take women to and from their appointments free of charge. And for women who do have insurance and therefore wouldn't qualify for our program, we still offer navigation services because we do want to get as many women screened as possible. And we're able to deliver these services through contracts with local service providers such as SSM, Barnes, Mercy, CareSTL, Betty Jean Kerr Peoples, and Affinia. Local partners such as the ones you see listed can provide things such as support groups and one-on-one support, healthy lifestyle and stress management programs, comfort kits and supportive bras for the newly diagnosed, and help with payment of non-medical bills during treatment such as mortgage and rent and car insurance. We want to take the whole picture into account. So the next slide is actually a short testimonial from a previous Show Me Healthy Woman client. So I'll let you listen to her experience. And hopefully this works. So if you can navigate to the next slide. Cool. Looking like it's not playing the audio. Well, I will put in a link after I'm done presenting, and you can navigate to the video yourself. It's a pretty informative little video. Maybe if it unmutes. Oh, well, there you go.
I felt a lump in my breast, called Dr. Coble, made an appointment, and had me to go and do a mammogram and ultrasound.
After the mammogram and ultrasound, Cassandra was referred to Siteman Cancer Clinic for additional tests.
They called me to let me know that the biopsy was cancerous.
Like Christine, Cassandra's treatment included chemotherapy, a surgical procedure, and radiation therapy. But Cassandra says none of that would have been possible without the Show Me Healthy Women program.
She asked me if I had insurance, but I didn't have insurance because at the time I was not working, I was unemployed. And they told me about the program. I filled out the paperwork and I went to Siteman. I had, insurance.
Cassandra says the Show Me Healthy Women program helped her get the treatment she needed free of charge.
Everything, the ultrasound, the mammogram, the biopsy, the chemo treatments, the surgery, and radiation. And so.
All right, so we can navigate to the next slide real quick. I think if you click like on the pink area, that should navigate it forward. In the background. Yeah, there we go. So you can click it there, perfect. So hopefully you're all still with me and you're thinking, how do I qualify for this wonderful program? Well, the three main criteria for determining eligibility include insurance status, age, and income. Additionally, services are available for female to male transgender clients. So as you can see, a client can be either uninsured or underinsured, which would involve something like your insurance not covering services, or you can't afford your premium or deductible. The next is age. So we do serve women between ages 35 to 64. And last is income. So 200% at or above poverty level can sound quite a bit confusing. So this chart helps clarify for what that actually means. So a woman with a household of 4, for instance, can make up to about $52,000 per year before taxes and still qualify. Now, family history of breast cancer alone does not qualify a woman for routine mammograms. A clinical breast exam is always done as a starting point prior to more detailed screening such as mammograms, and it is required once per year of all program participants. Now, if after your clinical breast exam something looks a little off, or there's any type of lump or dimpling, anything, we will move you forward to a diagnostic mammogram, and those services would be covered. Routine screening mammograms are offered annually or every other year, depending on what you and your doctor decide, beginning at age 50. Now, in addition to breast services, a complete visual and manual pelvic exam is done once per year for all women between 35 and 64. A pap test, additionally, is for women without or with the cervix, is available every 3 years, or if combined with HPV testing, every 5 years. And if you do not have a cervix, there are certain caveats to that, and we can go over those more in the questions. So if you want to navigate to the last slide for me real quick. So in conclusion, it's highly likely that you or someone you know may benefit from the Show Me Healthy Woman program. So please don't hesitate to reach out to either myself or check us out at health.mo.gov and navigate to Show Me Healthy Woman. Just remember that early detection does save lives, and we are here to help connect women with these essential services. And that's about it for me.
Thank you. Hi, everyone. My name is Helen Blair. I am the Breast Health Navigator for Christian Healthcare and Northwest Healthcare. You can go ahead to the next slide. I service, again, the North County area location. Again, that's Christian Hospital and Northwest Healthcare. My primary role is to navigate those patients with newly breast cancers. Go to the next slide. My role includes things such as coordinating those patient appointments, facilitating healthcare discussions between the patient and their loved ones, as well as the physicians. I assist with some of the breast procedures. I try to help reduce those barriers that interfere with those patients that are trying to receive services. I am now helping implementing the Show Me Healthy Women's program out here in North County. You can go ahead to the next slide. And some of those things I assist with within the Show Me Healthy Women's program is identifying some of those patients, contacting them, and going over the screening process that Cameron mentioned for the Show Me Healthy Women program. I further explain the procedures that the patients will be receiving. Again, I assist them with transportation to and from their appointments. We go over their income and insurance to make sure they meet those criteria. And I continue to do that education as far as breast cancer prevention and awareness. And I think that's all I have.
Hi, I'm Michelle Silver. I'm an assistant professor in the Division of Public Health Sciences in the Department of Surgery at the Washington University School of Medicine. My background is in epidemiology and health services research, and I focus on screen detectable cancers, primarily cervical cancer, also some colorectal and lung cancer as well. But today I'll focus on some background information about cervical cancer. If you could go to the next slide, please. So although rates of cervical cancer have been declining with screening in the United States for the last 40 years or so, there are still several disparities in the country and in Missouri as well. This is showing the difference in incidence and mortality between Black and white women in the state of Missouri. And if we see that there's between a 49% higher incidence in Black women and a almost 91% higher mortality rate in Black women. There's also a large disparity between rural and urban populations, although I was not able to pull those numbers directly, but we also see higher rates of cervical cancer incidence and mortality in rural populations compared to urban. Next slide, please. So cervical cancer develops as a result of an infection with the human papillomavirus, or HPV. So HPV is the essential cause of cervical cancer. Without an HPV infection, you won't develop cervical cancer, but just because you do have an HPV infection does not mean that you will necessarily develop cervical cancer. And this is because HPV is a very common infection. Over a person's lifetime, more than 80% of sexually active people will get an HPV infection at some point. And most of the time that's not a problem because your immune system is able to control it and you have no further problems after that point. But there are some rare occasions where that infection does not go away, and those persistent infections are the one that can potentially lead to cancer. Next slide, please. So I just wanted to talk a little bit about what the risk factors are for first getting an HPV infection, and then for those who do have an HPV infection, what potentially could increase their risk. So HPV is a sexually transmitted infection, and so having more sexual partners or beginning to have sex at a younger age just gives you a greater potential exposure to the virus, and that can increase your risk for becoming infected, as well as having a weakened immune system since your body is not quite as able to control the virus as easily. And then for those who do have an HPV infection, a higher number of giving birth to a higher number of children, smoking cigarettes, or using oral contraceptives for a long time can also increase the risk of developing cervical cancer. Next slide. But we are very lucky in that cervical cancer is preventable. It's a very slow growing cancer, and so it takes many years to develop from an HPV infection all the way to a cancer. And this is why we are able to use routine screening to detect early signs of infection or even precancerous lesions. And then we have really effective methods to treat the precancers and remove them, and that can prevent the development of cancer in the first place. Screening also enables us to detect cancers earlier when they are more easily treatable and have better survival rates. On top of having good detection and treatment, we also have a vaccine that's able to prevent the infection with HPV in the first place. And so if you're not going to get infected with most of the types that can cause HPV types that can cause cancer, we're able to also prevent it in that way. And the vaccine is safe and highly effective. And I think we'll be hearing a little bit more about that shortly. So I just want to emphasize that increasing access to screening and vaccination can help reduce both the racial disparities and also the urban-rural disparities that we see in Missouri. Thank you.
Hi, good morning, everyone. I'm Lindsay Kuroki. I'm an assistant professor in the Division of GYN Oncology at Washington University. And I really want to thank you guys for the opportunity to talk today on behalf of PECaD. So I wanted to start off by starting on the first slide, if you could advance, and just really highlight that the effectiveness of the cervical cancer screening is dependent on that people have access to screening and then follow up with guidelines if they should have an abnormal PAP result. So as you just heard from Michelle Selver, you know, not only is cervical cancer preventable, but essentially there still exists some disparities, not only by race and ethnicity, but geographic location and socioeconomic status. And I can't stress enough today that there are missed opportunities to improve our cervical cancer screening so that we could certainly continue to decrease the rates of incidence and death related to cervical cancer. So just to make sure everyone starts off on the same page, remember the primary goal of cervical cancer screening is to detect treatable precancers that are likely to progress to invasive cancer. And in doing so, we can reduce the rate of cervical cancer diagnosis and death, and importantly, you know, treatment-related side effects for those that do have cancer. You can see along the bottom of my slide that essentially there's a continuum of care. You know, vaccination is an excellent opportunity for primary prevention of cervical cancer. And then you can see then that there's screening opportunities starting as early as age 21. And for those that have consistent normal screening results over the last 10 years, that their risk for cervical cancer is low enough that in those low risk patients, we can potentially exit them from screening. I'll ask you to go to the next slide. So how is cervical screening actually performed? Generally, this is done in the office setting. It is in addition to a pelvic exam. You can see that we place a speculum, which is the silver instrument, into the vagina, and then look at the very inside of the vagina, which is where the cervix is. And the cervix is then brushed with a little white bristle tip. And what we're essentially doing is collecting the cells on the outside surface of the cervix. And those test results generally come back between 7 to 10 days, depending on the office and the laboratory. You can go to the next slide. In terms of what tests are available and how frequently people need to obtain their follow-up for screening, I've broken this down essentially to highlight the newest guidelines that are available from the American Cancer Society. So I wanted to highlight specifically the starting age is 25, and the preferred test is the primary HPV test. It's recommended that if we're able to screen with this specific test, if the test is negative, then screening would then be recommended in 5 years. When these guidelines were recently issued, there was acknowledgement that not all laboratories and offices have access to the primary HPV test. And so in this transition, it is very reasonable that women are still screened with cytology alone every 3 years if their test is negative, or with a co-test, which is a pap smear with an HPV test at the same time, and if negative, can repeat in 5 years. I want to mention that the U.S. Preventative Services Task Force has not yet updated their guidelines from 2018, and so as of right now, their guidelines still say that for their starting age, screening is still recommended at age 21. But again, what I'm showing here is the newest and updated guidelines from the American Cancer Society. What the societies do agree on is how we should be thoughtful about when to exit women, specifically low-risk women, from cervical cancer screening. And so as it stands now, age 65 is generally the age cutoff, with the important caveat that these women should have documented consecutive and consistent negative screening over the last 10 years and should have not had any prior diagnosis of a high-grade precancer lesion in the last 25 years. So although we think of an age cutoff, it is more than just an age cutoff. We're thinking of an age cutoff, but women who are at extremely low risk and have documentation of consistent screening to help us identify those patients who are at lowest risk, and that wouldn't necessarily need to have cervical cancer screening, though established care with a pelvic exam is still very reasonable and recommended. I highlighted, importantly, those women actually who have had a hysterectomy. And to be clear, it's a hysterectomy means that in this scenario, the cervix is no longer there. And in women who have had a hysterectomy with no cervix left, these women do not need additional screening after their surgery only if they do not carry a history of ever having a high-grade precancer lesion. And I think this is where it's just really important in general to advocate for better access to personal health records, and to make sure that, even from provider to provider, that we're communicating with each other to make sure there's consistent documentation. And then I think the burning question that a lot of people have is, now that there's more and more, but still not enough, people gaining access and getting their vaccine series for the HPV prophylactic vaccine. As of right now, there are still no specific guidelines that adjust or adapt these intervals or when to initiate screening for individuals who are vaccinated. Next slide. One of the last slides I wanted to review was essentially what symptoms should you guys look out for? How do you know you're at risk, and what signs should you talk to your providers about? I think the most important is that no matter how much I can point out these general symptoms, one, they're very vague, and two, in general, a lot of women with abnormal pap tests don't have symptoms. So the most important is that screening is for women who actually don't present with symptoms, which is why having routine follow-up screening is so critical. But to be a little bit more specific about when these symptoms develop, it generally is in women who are in later stages of, precancer lesions, and more importantly, those that have more concerning exam findings for cancer. These include abnormal vaginal bleeding, unusual discharge from the vagina, painful intercourse, feeling more tired or fatigued more so than usual. Any change in your bladder or bowel habits is always important to discuss with your provider. Unintentional weight loss, and essentially, if you notice any difference from your baseline of new or pelvic pain that just doesn't go away. Next slide. That's it. Thank you.
Good morning. My name is Nicole Cope, and I am the Executive Director of the Missouri Immunization Coalition. And I would like to extend my thanks for being able to participate in today's town hall. Next slide, please. So today I'll talk quickly about the human papilloma, or the HPV vaccine. It has been around and approved by the FDA for 15 years. And has close to 100% efficacy rating. So Gardasil 9, made by the manufacturer Merck, is the only FDA-approved HPV vaccination. The original Gardasil vaccine came on the market in 2006 and protected against the four most common cancers and diseases caused by the HPV vaccine. Caused by the HPV virus. In 2014, the FDA approved an updated version of the Gardasil called Gardasil 9. This vaccine extended vaccination coverage to the additional 5 common cancers and diseases caused by the HPV virus, which included cervical, vulvar, vaginal, and anal cancers, as well as genital warts. This vaccine, Gardasil 9, was also approved for use in individuals 9 to 26 years old. And in 2018, the FDA approved Gardasil 9, the HPV vaccine, for individuals 27 to 45 years old. In June of 2020, so just last year, the FDA expanded the indication and approval for use of Gardasil 9 to include the prevention of oropharyngeal and other head and neck cancers caused by the HPV virus. Next slide. So, like I said, the HPV vaccine is almost 100% effective in preventing cancers caused by the HPV virus, the most common ones. And in 2020, oropharyngeal cancers became the most common malignant cancers caused by the HPV virus, surpassing cervical cancers. So the following are the cancers linked to HPV infection that can be prevented by Gardasil 9, the HPV vaccination. In women, they are cervical, vulvar, vaginal, anal, oropharyngeal, and other head and neck cancers caused by the HPV virus. In men, they are anal, oropharyngeal, other head and neck cancers caused by the HPV virus, as well as precancerous or dysplasic lesions that can be caused by the HPV virus. Next slide. So who should get the HPV vaccination? Like I said, in 2018, the FDA approved the Gardasil 9 HPV vaccination for men and women up through the age of 45 years old. But the most common age group for all people to receive the vaccine is age 9 to 26 years old. The men and women in the age group of 27 to 45 can receive the vaccination in consultation with their physician because they need to talk about the risk of new HPV infection and the possible benefits of receiving the HPV vaccine. The reason for the doctor's consultation is because more people in this age group have already been exposed to the HPV virus. So how is this vaccine administered? It is given in the upper arm, or what is called an intramuscular or an IM injection. Next slide. So here is the 2021 CDC recommended schedule for the HPV vaccination. The HPV vaccination is what we called a multi-dose series. So if you receive the first dose anywhere between the ages of 9 to 14 years old, it is a 2-dose vaccination with the second dose 5 months after the first dose. And once you receive both vaccinations, you're considered vaccine complete for the HPV vaccination. If you receive your first dose anywhere in the age group from 15 to 26 years old, it's a 3-dose vaccination series. So between the first and second dose, there's a 6-month interval. And between the second and third dose, there's a 4-week interval. Again, once you complete all 3 vaccinations, you are considered vaccine complete for the HPV vaccination series. For those individuals that, after consulting with their physician, decide to get the HPV vaccination and are in the age group of 27 to 45, it's either a 2 or a 3-dose series, depending upon the initial age of vaccination. So if they received their first vaccination somewhere between 9 and 14 years of age, they only need a second dose to be considered vaccine complete. If they received their first dose anywhere from 15 years of age and older, then they need to receive all 3 vaccines doses to be considered vaccine complete. This vaccine is what's called an interrupted schedule, meaning that if you miss or have a delay between doses, you do not need to start the entire series over again. You just pick up where you left off. Next slide. So in summation, the HPV vaccine has been recommended since 2006 and has significantly reduced the incidence of HPV cancers. Fewer teens and young adults are getting genital warts. The HPV vaccine has reduced the number of cases of precancers of cervical cancer in young women. And the HPV vaccine does not lose ability to protect against new HPV infection over time.
All right, thank you so much to all of our panelists. We're going to move into the Q&A portion of today's conversation. So I'll actually invite all of our panelists to turn on their video for us all. I have some prepared questions, but I see some coming through the Q&A, so thank you so much. We'll go ahead and get started. And Helen, I'd actually like to start with you. Thinking about breast cancer and screening mammograms, we heard some of the requirements for the cervical screens, but can you walk us through the different requirements for mammograms and screening mammograms and how those might vary by age?
Well, the recommendation for all women is for women 40 and older. They should have a mammogram every 1 to 2 years. Now, women that are younger than 40 and have those risk factors, we recommend them that they speak with their medical provider and see what was the best age for them to start. And that will usually be in between 25 and 30.
You mentioned individual risk factors, and we heard from Cameron about the history of family history of breast cancer. If a patient does have that family history, how might that change their recommendations for a screening mammogram?
Well, if a patient has that family history of breast cancer, it puts them more at risk. And when that happens, we recommend that those patients get their screening earlier, especially genetic testing. The age would be starting at, we would like to start those patients at the age probably 25 to 30 with their screening. Now, what puts them at high risk if they have that first degree relative history, which would be the parent, the brother, the sister, or child, or a second degree relative history, such as aunts and uncles, nieces, and grandparents. And then there's a time when we have the third degree relatives, such as their first cousins. When they have those family members that have had the BRCA1 or BRCA2 mutation, we suggest that they get genetic testing early.
Thank you for going over those recommendations and guidelines. And my last question for you, Helen, is how should a patient prepare for a mammogram? Is there any recommendations that you might have either for a first-time patient or a routine patient that's coming in for that screening mammogram?
Is coming in for that screening mammogram? Well, we just really ask that the patient wear no deodorant, lotions, or cream up under the arm. We ask that because when patients have those chemicals on their skin, it shows up in a kind of white, gray area on the mammogram, which could cause some false concerns that aren't really there. But that's really the only prep for mammogram. It's just kind of not to have those patients have any skins or lotions. Wear something comfortable that they can easily take off and put back on. They'll need to disclose from the waist up. We try to prepare them about the mammogram machine. It causes some discomfort to some patients and to others not so much. We tell them about the degree of pressure that they may feel within the breast while we're taking those images, and we also go over when they can expect their results. And usually results come back within 2 to 3 weeks. If there's anything abnormal with that mammogram screening, the patient hears from us much sooner, as we like to get them scheduled for diagnostics such as diagnostic mammograms or ultrasound imaging.
Wonderful, thank you, Helen. Dr. Kuroki, what about recommendations for a patient coming in for a cervical screen? How can they best prepare?
You know, I think honestly, just having an open mind that this is an important screening test. I feel like people just need to know that in general, it's a quick exam. And I really want to emphasize that actually most people might not be able to distinguish between a visual pelvic exam and actually obtaining a Pap test. Because I've had plenty of patients actually come into my office and say, oh, I recently had a exam and a Pap done just 3 months ago, and I'm looking through their records, and either I don't see it or I have just that the referring provider just did a documented pelvic exam without a Pap test. So I think don't assume just because you've had a prior pelvic exam that it included a cervical cancer screening. But really it's quick, it's easy, it's fast, but just go in knowing that you can do it. Everyone can do it. It's a really simple and quick, easy test.
Thank you. And we heard a little bit about the variations to guidelines and that there are some discrepancies. Are there any women or patients that would follow a kind of a different routine cervical screening guideline, or is there any kind of risk factors that might change some of those recommendations for different patients?
Yeah, so, what I presented were general screening guidelines for low-risk patients. And I think hopefully I could, address your question by highlighting who the high-risk patients are that don't necessarily follow these initiating screening tests. And so those are the immunocompromised patients. Whether that's someone who has HIV, regardless of how they got that diagnosis, but also immunocompromised patients that might have undergone like transplant, surgery, and our immunosuppressant medications for like other medical conditions like rheumatoid arthritis or lupus. So it really encompasses a broader population who are immunocompromised. And in those situations, for example, the HIV patients, their screening gets initiated earlier if they get diagnosed with HIV before the age of 21. And then in general, if they start initiating screening, their interval frequency is a lot shorter. So to not belabor like the small nuances of details, there are exceptions. And these exceptions are to women who are at increased risk for cervical cancer and in general who are immunocompromised. So I'd really talk to your providers and make sure that they're appropriately reminding you who and how often we should be screening.
Wonderful, thank you. We got a question in the chat related to Show Me Healthy Women. And I think one of the questions in here is how can a patient know if their provider is a Show Me Healthy Women? So how can patients find who Show Me Healthy Women providers are? And then the other piece in here is how do we make sure that there is travel options for them? Not all providers in Missouri are Show Me Healthy Women providers. So if your nearest provider, so you find your providers first, and then if your closest provider is not a Show Me Healthy Women, are there resources to be able to provide travel vouchers to other providers that are Show Me Healthy Women? So I guess the questions is twofold, Cameron. How do we find Show Me Healthy Women providers, and how do we make sure our patients can get to those providers?
Well, you can navigate to the link that I had earlier with the health.mo.gov, but honestly, the easier way to do it is just to go to Google and type in Show Me Healthy Women. I did that just a second ago, and as soon as you type that in, it pops up with provider lists as one of the main things, or locate a provider near you. And when you click on that, it will navigate you to either an alphabetical listing of the providers, or an easier way is the clickable county map. So if you're in St. Louis County or St. Louis City, for instance, you would just click on that and it'd give you, the different providers. Now, it wouldn't say which ones provide mammograms and which ones, provide certain services, which ones don't. But if you do, for some reason, go to a provider that doesn't have a mammogram, I've noticed that they're very good at getting you connected with a place that does. And the travel vouchers actually do apply to getting you to and from different providers if you need be. And if for some reason, the provider that you went to, you got a screening mammogram there, you got a clinical breast exam there. If for some reason they don't offer Show Me Healthy Women services, they can actually refer you to what's called like a direct biller. And then that office would be able to get you your mammogram and then be able to get any services that you need. We are, trying to expand as much as we can. So hopefully the map keeps getting big. We have quite a few just in the St. Louis region, but yeah, you should be able to get services one way or another, even if the place you're at doesn't offer the services.
And if a patient has already been diagnosed with either cervical or breast cancer, do they still qualify for those services, or do they have to start in those screening stages?
So for the Show Me Healthy Women program, it specifically states that it's for women who have not currently been diagnosed. So women that have been diagnosed or that are currently being treated for breast or cervical cancer, they're not going to be eligible for our services. We're not going to leave you hanging though. We want to help everyone. So even if you have been diagnosed, you can give me a call, or you can, email me or something, and I will get you connected with places that will help you out. So there's a wonderful place called Gateway to Hope. They have income guidelines, but they're a little more generous. So sometimes, you can get things covered with that, and they help with, your bills and stuff. So there are resources out there besides our program. We want to connect as many people as possible to knock cancer out.
Thanks, Cameron. I'd actually like to open the next question to all of our panelists. Throughout our conversation today, we've heard that early detection is key. And we've also heard that there are disparities and that there are barriers that exist that sometimes kind of put roadblocks in place to that early detection or some of the preventative screens. Thinking about our patients and thinking about your patients, what can we do to increase access to some of these wonderful services, be it Show Me Healthy Women or screening or the HPV vaccine, breast mammograms? What can we do to increase or reduce some of the barriers that you all see to kind of see better screening rates and have better opportunity for early detection?
I can start. You know, part of my clinical research is actually on looking at assisting women with unmet social needs. So it's really a much broader issue than I think, you know, we can even begin to address in our clinics, because there's just so, you know, much that we can do. But in order to prove access, I think it has to come from the community level. And I think it really has to do with increasing conversations, working with, you know, public health policy officials to really start disseminating and implementing what we know to be very highly effective, you know, primary and secondary prevention services so that we can prevent, you know, these cancers. I think, you know, in my field in G1 oncology, there's such a rare opportunity to prevent a cancer. And yet we have great screening tools for cervical cancer, and we have a vaccine that's so effective. And I think it's just getting people access to the care that they deserve and that they need, and to improve health equity for the community. And I think that starts with, you know, at all levels, not just healthcare professionals, not just patients on being diligent about keeping their appointments, but it comes from everybody. It comes from health city officials. It comes from public health officials. It comes from schools and, you know, parents and, you know, peers advising each other. So I think the onus is on all of us. But I do think it starts with people taking a responsibility and a stance.
I agree with Dr. Kuroki. That's one of the issues that we're having out here at North County with Christian Hospital and Northwest Healthcare. We're trying to start those communications, get the word out to the community that the Show Me Healthy Women's program is back in North County. It was out here before, but just due to a lot of geographic and other hospital related big things, the program was kind of set to the side. But now we're up and running. So now we're just focusing on getting out in the community, talking to the pastors, the community leaders, maybe going to libraries and, you know, putting pamphlets up, or, you know, just having those conversations with friends, relatives. Usually when I have patients that are here, you know, for procedures and I'm assisting them, I always give them a brochure with my card to let them know that they have any family members that doesn't have any insurance, or, you know, they haven't had their pap testing or breast screening, to please give me a call.
I would just build off of that to say we know what works, in especially for cervix, but also for breast. If you're getting screened regularly, it's very effective, but that's not enough. I think we really need to be working with the communities to figure out how to put those things into place, whether it's training providers on how to recommend the HPV vaccine more effectively, or educating parents about how data on how the vaccine is safe in a way that's understandable, involving people not just at the clinician level, but also the, you know, the staff at the front desk and the nursing staff and the MAs and everyone else, to be able to have a conversation about the need to screen or the need to get vaccinated, and that you're getting consistent messaging across all of these things.
I'll caveat off of what Michelle just said with the vaccinations. Like I said, the age group for vaccination is 9 to 26 and then 27 to 45 in consultation with your physician. The recommended age to start the vaccination from the CDC is 11 or 12 years old. But what they're finding right now is that the earlier you start the vaccination, so if you start the series closer to 9 or 10 years old, it takes out the stigma, if you will, of HPV being a sexually transmitted disease, because that is not something that most parents of a 9 or 10-year-old are thinking of yet. But if you get closer to preteen and teenage years, then that complicates the decision for the parent to have their child vaccinated.
Cameron, any final thoughts about how we can reduce barriers and increase services?
Well, I think in terms of increasing services, everybody on this call is already taking a great first step in just trying to figure out more about why they need these services and how they can get more access. And as you mentioned, it is going to be on YouTube. So even if you can't utilize these services, please forward the link to anybody that might be able to utilize them, and just kind of getting the word out there about why these services are important and how we can prevent and treat things in the earlier stages and help women out.
Wonderful. And it looks like we've got a link here to PECaD's YouTube page where we will be posting the recording from today. And I do invite you all to disseminate this recording to any of your colleagues that you think might benefit, or your friends and your family. We heard from Helen, word of mouth is great for getting those screening up. So if you know someone, or maybe think about your own medical history and how perhaps it's time for a screen. And I'd like to go ahead and see if we've got those post-test results yet. I'm looking forward to see how we collectively did. So if you go ahead and take that post-test if you haven't yet. And again, thank you to all of our panelists.
Melody, before we break, I just wanted to mention, I don't think that I mentioned that North County, we do offer the breast screening as well as the cervical screening with our Show Me Healthy Women part of the program. So I just want to make sure that everyone, all the women, are aware of that.
Thank you, Helen.
Mm-hmm.
Any final thoughts from our panelists? Well, I'd like to, on behalf of PECaD and Simon Cancer Center, I'd like to thank everyone for participating today and for everyone that joined in on the call. I learned a lot about cervical screens. I certainly know more about the breast cancer side, so I learned both breast and cervical screens today. It looks like we've got our polling results. So based on our results here, it looks like we've got that depending on the age, whether a person for their cervical screen, depends on when the person received their HPV vaccine. Any final comments from our panelists related to this response here?
I'll take this one. It's just that, as of current guidelines, we haven't yet adapted when to initiate screening, and it's regardless of whether you've been vaccinated or not. So it does not depend on whether you have actually started, initiated, completed, or have never received the vaccine. And so the data I presented was from the American Cancer Society to start at age 25 with the primary HPV screen, but the U.S. Preventative Services Task Force has not yet taken that leap and says age 21 is reasonable. But again, it's not dependent on HPV vaccine status.
All right, our second question here. Early detection of breast cancer relies upon frequent breast self-exams and routine mammograms. Any final thoughts, Helen, on or even Cameron, on clinical or frequent self-breast exams and routine mammograms?
I would definitely say that is true. I think that it's important for females to understand the importance of doing those breast self-exams and coming in for their routine mammogram. One thing we didn't mention, what I didn't mention, was some of those signs that female or male needs to be aware of with breast cancer. Some of the signs and symptoms. If you don't mind, I would like to kind of go over a few of those.
Okay, thank you.
Okay. So we like to have patients to be aware of any new changes within the breast. Anything like unilateral swelling or maybe shrinkage of the breast. Look for those lumps. Any things that feel hard, that that's not movable, or those things that feel squishy and movable. We like patients to make sure they're checking their nipples, make sure their nipples aren't changes, whether they're being inverted, being pushed in and versus out, looking for nipple drainage, It could be milky, but we're really concerned with those clear drainage and bloody drainage. Just anything that looks different or abnormal. Look for that skin that begins to look kind of hard and rough. I kind of describe it like an orange. You see the pores kind of look like a hard orange peel. If your skin start to, look like that, with big pores and hard, we ask that you seek help from your PCP, or, come in for their mammogram screening. Any hard, tender, or soft, tender parts of the breast, we want you to have those checked out as well, because while all these signs and symptoms may not be a result of cancer, but it's definitely something that needs to be investigated.
Thank you, Helen.
Mm-hmm.
Nicole, how do we do on our question? Men and women ages 27 to 45 years old are able to get the HPV vaccination after consultation with their doctor.
Absolutely. I saw that it was 100% correct answer on that. So again, that was a new recommendation starting from the FDA starting in 2018 with consultation with your physician, because this age group has more than likely already been exposed to the HPV virus. So it needs to be in consultation with your physician for the benefit for you.
Thank you, Nicole. For Cameron, true or false, individuals with insurance coverage are eligible to participate in the Show Me Healthy Women program?
That's kind of an interesting question, because one of the main eligibility things for the Show Me Healthy Women program is insurance coverage. And if you do have insurance coverage, generally you won't qualify for the program, but the caveat is if you do have insurance and say you can't afford your premiums every month, or you can't afford a premium for Medicare Part B, for instance, or you can't afford your deductible, that's where we step in, and then we cover whatever you can't afford or whatever is not covered by your insurance. So we kind of work in tandem, but in general, if you do have insurance and things like those tend to be covered, then you wouldn't qualify. But if you have any questions, you can always give me a call or shoot me an email just in case.
Thank you, Cameron. And I just want to extend a sincere thank you to all of our panelists. I know we didn't quite get through all of those post questions, but if you have any questions about cervical screens, the HPV vaccine, breast screenings, please reach out to Crystal and she can help direct you towards the panelists that might be able to kind of continue these conversations. So again, on behalf of all of our colleagues here at PECaD and Siteman Cancer Center, thank you so much to the panelists, and enjoy the rest of your Thursday. Bye.
You.
Thank you.